Today's topic of debate is very, very interesting, and this is what we have been discussing. Early screening for type 1 diabetes in at-risk population, feasible and beneficial. This is the question. And Dr. Swati is going to talk on yes, it is beneficial and feasible. Over to you, Dr. Swati.
Thank you, sir. And thank you very much for making me come here and talk about this topic, which is very close to my heart. And I'm very happy to finally meet the pediatric diabetes interest group people, which we haven't done so far. So the topic is early screening for type 1 diabetes in at-risk population feasible and beneficial? Yes, it is. And I'm sure you would agree with me by the time I finish. So, the common scenario that we see is a child who has been well so far, no problem, suddenly develops stomach ache and is not well for a few days and everything. Suddenly, the parents take the child to the doctor, thinking it might be some viral infection or weather change or something. Child ends up in ICU in DKA, and parents are like, they're shocked, they're flabbergasted, they have absolutely no idea what has happened to their child who was well 15, 20 days back, and now they are being told that it's a permanent diagnosis, that the child has type 1 diabetes, would require multiple blood sugar checkings, would require multiple injections probably for life. Well, what would you tell such parents? You have no answer why this has happened and what are we going to do about it, except that we're going to treat it with insulins. So DKA, the most common presentation a type 1 diabetes presents with, can significantly reduce life expectancy potentially up to 8 years or more. And why this happens is that severe hyperglycemia and systemic inflammation associated with DKA can cause depletion of the functional pancreatic islets, can lower the residual beta cell function, has higher insulin requirements, worse glycemic control, and long term damage to organs like kidneys, eyes, nerves, and blood vessels can lead to future complications. And if we have prevention of decay, that would eliminate the potential morbidity and mortality associated with cerebral edema at diagnosis and may provide considerable cost savings by reducing the days of hospitalization and use of intensive care units. Don't we all want that? Now, child has been diagnosed with type 1 diabetes. Now, the parents are concerned, maybe what is the chance of sibling developing type 1 diabetes? What the relatives are worried, what are our chances of developing type 1 diabetes? So, relatives of patients with type 1 diabetes have 15-fold increased risk of disease. Siblings have 6 to 7% lifetime risk of type 1 diabetes, and offsprings of mothers and fathers with type 1 diabetes have risk of 1.3 to 4% and 6.9% lifetime risk. But as we all know that 90% of those who present with new type 1 diabetes do not have a positive family history. Now, as we have spoken already about the stages of type 1 diabetes progression, we all know that children with diabetes, with genetic risk, they have an immune activation and immune response in their body, which leads them to stage 1 of developing autoantibodies without dysglycemia. Then they have a stage 2 of autoantibodies with dysglycemia and a stage 3 where they finally develop with type 1 diabetes. So, uh, these are the two stages actually that we need to work on to prevent the onset of type 1 diabetes, and this is where the research has been going on for years. There have been a lot of screenings which have been happening. So screenings of relatives, there's various studies which have been happening, and the screening in general population, which either focuses on genetic screening with autoantibodies follow up or screening for autoantibodies alone. And some of the studies have been done from the birth and followed up to 15 years of age to see the progression. And studies have shown that the children with 2 or more autoantibodies, 74% of them will progress to stage 3 type 1 diabetes within 10 years and 85% within 15 years. And children who are at stage 2, that is autoantibodies plus dysglycemia, 75% of them will have stage 3 type 1 diabetes within 5 years. Isn't that scary? So now let's come to benefits and risk. Everybody is like, oh, why should we do screening and everything? Let's talk about it. If there is early identification, monitoring, and regular follow up of high risk individuals, it can reduce the DKA rates from 25 to 62% to 4 to 6%. How much money we would save if a child does not go into DKA? People say there would be a negative psychological impact on those who screen AA positive. Oh, they would be so scared and they would be so tensed over the years. But the studies have shown that the stress appears to wane over time and it gives them more time to be prepared for it. Majority, 95% of the relatives of individuals with type 1 diabetes are autoantibody negative at screening. Wouldn't it be so reassuring for them that they know that they do not have the autoantibodies? Now, about the cost. Everything comes down to cost because in India we pay from the pocket. So that is why it can be so cost benefit. It has been seen that the screening and follow up would be cost effective even if we reduce the rate of decay by 20%. And it has been suggested that we can actually test the children at 2 years and 5 to 7 years of age group, and the screening can be done in these children with other lab tests, which is very practical to do. And these are the age groups where the maximum autoantibodies happen and the type 1 diabetes development happens, and we can catch them at this stage. On a recent survey of the healthcare practitioners from 76 countries, it was indicated higher support for screening in low income countries due to increased occurrence of decay and mortality associated with undiagnosed type 1 diabetes, because to this day any child who comes as a sick child who might have a stomach ache or he might be having some viral infection like picture, blood sugar is not checked, type 1 diabetes is missed. So the preventive therapies, Dr. Manoj has spoken about a lot of preventive therapies, and so we should be very happy that we have teplizumab with us, which is an FDA-approved therapy and indicated to delay the onset of stage 3 type 1 diabetes. And in a study, it was seen that the children who received teplizumab, the stage 3 type 1 diabetes diagnosis was delayed by 48.4 months. So actually, we can delay the diagnosis. We can delay the onset of insulin. And now that there is an approved immunotherapy for treatment, type 1 diabetes meets the WHO criteria for establishing a universal screening program. So why is screening important? Helps diagnosis at risk individuals, enables access to medical expertise to discuss the results and provide ongoing education and monitoring, which is pretty easy to do, access to clinical studies and therapies to delay or prevent type 1 diabetes, prepares them for future, and post-diagnosis adjustment for subjects diagnosed through screening and monitoring compares favorably to those diagnosed with clinical symptoms suddenly. Avoidance of decay at diagnosis and acts as basis of future research. So, as it says in Princess Diaries, only prevention like this and this can take you to this. Thank you. Screening and prevention is the key.
Thank you so much. So we have heard for yes. Now we are going towards no. I would like to invite Dr. Mudita Dhingra. She is from our own Ahmedabad, a BJMC student. She has done his fellowship in pediatric adolescent endocrinology and diabetology from BJ Vadia Hospital. She has attended APES Fellow School Japan, awarded travel grant for oral presentation at Paris 2016, authored chapters in CDIC textbook, and special interest, which is very important, is technology in type 1 diabetes, childhood obesity, and lifestyle changes in children. And she is going to talk about no of screening. So, Mudita.
Yeah, good evening, everyone, and thank you, Dr. Nishil, for kind introduction. And it's a great pleasure to be back in Ahmedabad after 12 years. So I think Dr. Swati must have convinced you to screen all your patients and relatives with type 1 diabetes. However, in practical world, I'm going to make this topic very complex and very, it's a very complex when we are sitting in our OPD. So today I'll be talking on early screening for type 1 diabetes in at-risk population is not feasible or beneficial at the moment. Coming to the background, So we know that type 1 diabetes is an autoimmune complex disorder with multifactorial etiology. It can occur at any age, so from early infancy till even ninth decade. There is a complex interaction between genetics and environment. It is divided into various stages, and till now we do not have any cure. So the patient has to be dependent on insulin for his own whole life. And when we are talking about at-risk patient, they could be relatives of type 1 or they could be population screen identified with the help of HLA and antibodies. And when we are talking about relatives of type 1 diabetes, we are usually talking about first degree relatives like siblings and offsprings. However, there is some overlap also because third and fourth degree relatives of the patient are also going to be a part of the population. So coming to screening of type 1 diabetes in population, we know that 90% of those who develop type 1 diabetes do not have family history. So here what we are talking about is screening only those 10%. Most of the screening programs to identify individuals at risk for type 1 diabetes have targeted relatives of people living with the disease because of the ease of their studies and feasibility of their studies. However, there are a lot of hurdles in the process. We know that antibodies identify the risk, but not the speed of progression of clinical type 1 diabetes. It could range from few months to few years and even decades. Nearly less than 50% of the people in United States have HLA DR3 and DR4, yet less than 1% develop type 1 diabetes. And to complex the issue, we also have non-HLA genes responsible for type 1 diabetes. So let us hear a beautiful story here. Actually, not a beautiful story. A 6-year-old sibling of type 1 diabetes, and they have gone for the screening test, and the doctor has explained them that this child is an higher than average risk of developing type 1 diabetes in future. So this child has been now labeled as at risk of type 1 diabetes. Now what is the impact on the family? Now the mother has become frantic. She is cooking all low carb diet in the kitchen. They are all nervous, and the child is thinking what wrong he has done. There is whole weight of uncertainty in the family, and mother is continuously checking on internet for some magic treatment, and they are overthinking, and their quality of life is totally disturbed. So we actually order the test for an answer, but here we have lots and lots and lots of questions. And the healthcare professionals are also not sure how to counsel the family, which creates anxiety and panic. So we have to ask this question again, why did we order the test? Now coming to the challenges in screening these patients. So what is the goal? Why do we need to screen? Let us first ask this million-dollar question. We know that preventing type 1 diabetes is still a distant dream. So should we spend all our resources on early screening when it cannot guarantee prevention? Or should we focus on better public health measures instead? Are we only concerned about the sugars and DKA but not about mental health? We definitely need solution, not speculation. So this is the WHO criteria for screening any disease, and type 1 diabetes does not meet these three criteria. Starting from the psychological consequences, they have not been studied. The next is the natural history of the disease is not yet completely known, and the cost of case finding is also, the cost benefit ratio has also not been studied. So the only proven benefit till now is reduction in the incidence of diabetic ketoacidosis. Coming to the practical limitations of screening, we need specialized labs, trained personnel, complex counseling, and high cost. So Dr. Swati was talking about preventing the cost in DKA management. However, we are adding a huge amount of cost in testing these antibodies. Is mental health not important? It has not been studied yet, and it may impact negatively all the families. It can give rise to relationship issues, even divorces, child abandonment, and difficulty in adoption services. So even if we screen, does it have any economic benefits? It has been studied that the cost of autoantibody screening per case of type 1 diabetes detected before the diagnosis is around $4,700. I would rather spend that money on buying a basic insulin pump for a child with type 1 diabetes. Now coming to the evidence. So there are three major birth cohort studies which have studied the pattern of autoantibodies: the DAISY, the baby diab study, and the TEDDY study. Although all these studies are long-term prospective studies, they have their own limitations, and psychological part has not been studied in these studies. And still now we don't have any robust predictive models, and these patients are also on follow-up till now. Coming to this part of the TEDdy study, we were talking about preservation of C-peptide and its prognostication. So it has been proven that early diagnosis can improve C-peptide levels. However, there is only a small comparison study in which the natural history of C-peptide has been studied, and this difference is no longer apparent after 1 year from diagnosis. So although the loss of C-peptide seems to be parallel, ongoing follow-up of these children is very important to help to determine whether early symptom-free diagnosis of diabetes has long-term benefits. So still we need follow-up of these patients. Now in the DAISY study also, we can see here that checking antibodies is not very simple. So they have been divided into transiently positive, then persistently pre-diabetic and diabetic. So they have seen that 31% were false positive and none has developed type 1 diabetes over a period of 9 years. And none of the transiently positive children has developed diabetes. So can we even comment on the sensitivity and specificity of the test, because we need ongoing monitoring? And not only single test, we need at least 2 to 3 times antibody tests to classify the patient as positive or confirmed positive. So this is definitely an additional cost. So antibody testing is complex and continuous vigilance is required. This is also a very important article, and they have shown this novel approach for analysis of longitudinal profile, which reveals delayed progression to type 1 diabetes in a subgroup. So they have sequentially analyzed the antibody profile of children with possible type 1 diabetes in future, and the cohort which they have used is the study from the baby diab study. And they divided these patients into 9 clusters. And depending upon these clusters, these are the important findings of this study. First of all, the progression from first antibody detection to clinical diabetes ranged from 6% to 73% within 5 years. So there is a huge difference. And they looked into the factors which patients are developing diabetes early and which are having delayed diagnosis. So what they found that in patients who were IAA, anti-insulin antibody, negative in the last sample, they were having delayed progression as compared to those patients who were having IAA positive in the last sample. So 10-year risk of diabetes from seroconversion was 23% in those who became IAA negative versus 76% who remained IAA positive. However, to our surprise, HLA profile in both these subgroups were similar. So we cannot use only HLA typing for identifying these patients at risk. So much research, but do we have any hope? I think yes, some maybe. So we know that teplizumab has been approved in November 2022. However, it is not a cure yet, and it's just like a band-aid on the broken dam. So the dam is going to break in future. So there are some side effects, definitely, although the number of side effects are less, but there have been side effects in the study. And teplizumab can protect and preserve beta cell function, which is anticipated to affect short and long term complications. So here, there also they have mentioned that they have it is anticipated. They have not yet proven that it has shown long term benefits. This is also a very beautiful article on teplizumab, and here also they have mentioned that teplizumab has shown promising results in preventing disease progression. Metabolic benefits such as significant reduction in A1C have not yet been demonstrated, and definitely the limitations are these. So it's a huge cost. So while on one side we are trying to reduce cost on DKA management and look at the cost of treatment.
Last 50 seconds.
Yeah. So coming to my counterpoints, and I would like to conclude here that screening of at-risk individual is not feasible or beneficial at the moment because etiology still is not fully understood and impact thus cannot be predicted. Very large population data is needed. There are huge amount of resources and additional expenses even before the diagnosis of type 1 diabetes. We also need assay standardization. Psychological consequences have not been studied. There are lots of ethical and possible legal implications. Only delay is possible at the moment, and there is no 100% cure yet. DKA risk can be reduced by early diagnosis and awareness in the community. And even if we are screening, we are still missing more than 90% called at-risk patients. So I think many of us know him. He is Mr. Harsh Kohli. He is living with type 1 diabetes since many decades, and he is a strong type 1 diabetes advocate in Delhi and also a certified diabetes educator. His son also has type 1 diabetes, and when I asked him that whether he would have gone for the testing, he said, I would not have gone for antibody testing in my son for screening because it would have not changed the outcome and increased mental stress in the family. So we have to remember that we are not handling just enormous amount of data, but we are touching lives of real human beings. Thank you.